We're going to talk about teaching in busy clinics. I hope we all have busy clinics, which is good and bad. So how many of you here like to teach in clinics with patient, in front of you? Yes, I think all of us do. I think that's the whole reason, the charm of being in our specialty. How many of you here think it's quite tough doing it on a day-to-day basis from student to student? Okay, 50-50. Some of you seem to be comfortable teachers. Maybe you should be doing the lecture. So what I'm going to share with you are a few challenges of clinic teaching. So the challenges of successful clinic teaching are basically time constraints, balancing teaching with patient care. If you go on doing teaching, patients get upset because they've been waiting for a while. And my pediatric clinic, they all start crying or they go to sleep. Knowing the level of the learner, what to teach, how much autonomy to give, and teaching on the run. Obviously, many of the time we are just teaching on the run. It's not a sit-down lecture style of teaching. So, but as a contrast to other forms of teaching, which is like a lecture, this is unscripted. Every day, every patient, every student, it will change. And it's individualized. If you have a medical student, it's going to be different. If you have a first year PG, it's going to be different. You have an exam going PG, EGPG as we call it, it's going to be different. And it happens on the run in parallel with patient care. So objectives of this lecture are going to be to share strategies for time efficient and effective ambulatory teaching. I know some hospitals, we still have bedside teaching. My hospital, there are hardly any beds. Almost all patients are ambulatory. So this is going to be primarily clinic teaching. And preparing to teach, teaching with a patient, and reflecting on teaching. These are the topics in which we are going to, these are the objectives of the lecture. What do you mean by preparing to teach? So preparing to teach is again subdivided into initial orientation and orienting the learner to the patient. And we'll talk about each one of these in details. So, important to establish a relationship with the learner. What is the learner's background? For example, I just told you a primary candidate, a primary MS candidate versus a post-DO candidate. Their backgrounds are different. The primary candidate comes from knowing almost nothing. But a post-DO already has some sufficient fund of knowledge and you can start from that. What are their learning goals for the rotation? And I must share with you that my videos were not that successful, but I have anecdotes and stories for each. So that's what you will see in little brackets. So for example, in my hospital where we have many fellowships, we have the oculoplasty fellow rotate with us for a month in the squint and pediatric opthal service. Now what the oculoplasty fellow wants to get out of my service is different from what my pediatric opthal fellow wants to get out of my posting, right? What are your expectations? For example, you have to tell something about what kind of practice you are. So how many of you here are DNB teachers? National board teachers, right? So several of our institutions are private institutions. Our patients in a DNB institution are sometimes fussy, are from different backgrounds. So you have to tell them, look, our practice site has patients of higher profile, so you need to be careful what you say. You need to be sensitive when you examine the patient, not to say too much in front of them. So those things, when you say upfront to the PG, then it sets a nice tone for your posting. Next, you share your teaching style. You tell them, look, I don't like to be interrupted when I am examining and talking to the patient. Or you can tell them, feel free to stop me whenever and ask me questions. So your style of teaching needs to be explained to the student upfront. You also have to have your vision of the learner's role, professionalism, after hours learning. You tell them, look, I tell them, you have to carry a small notebook in your pocket, as and when I ask questions and you are blinking and don't know the answer, write it down. Next morning, before OPD starts, we are going to spend 10 minutes going over those answers. Or sometimes if they are very, very blank, I'll just send them to the library for 10 minutes. Go read up the topic and come. So you need to tell them upfront, this is what I expect you to behave, to be like when you're posted with me. And you tell them at the end of the posting or even daily, I will give you feedback, how you're doing. Okay? Your cover test is really still bad. You're not paying attention at all. You're mistaking all 4 years for tropias, whatever. You tell them, look, I am going to give you feedback right then and there and also tell you how to improve. So for the hyperlink open panna mudiyuma? Nane panna mudiyuma? Oh, I can do it. Okay. So I just wanted to share this. This is something I send by email to each of my students when they start their posting with me. For example, this is revised on January. It's called Pediatric Ophthalmology with Dr. MS. That's my short form. So on a day-to-day, my schedule is clearly said, told which day is OT, which day is OPD, from what time to what time. And then I tell them also, OPD general rules. Don't come late, always tell the truth. If not well, SMS me. See all the crosses, take coffee break, lunch break when you want, etc., etc., etc. So I have this sent to them ahead of time. Don't come in a dirty white coat, I will send you back. So on, you know. Don't go out of my room and check your mobile for WhatsApp. If I catch you stealing glances at your mobile, I'll send you back. So all my important things which are important for me for professionalism are told up front. If you come poorly groomed and unshaven, I'll send you back. Don't enter the room when I'm examining a small child or a VIP. Suddenly the door will fly open. You'll be trying to examine one infant who's been wailing for half an hour, and your PG will come and try and put their face next to you to see what the child is doing. Then that's it. And they would have come from Dharbanga, finished, exam over. So things like that. Again, OT general rules, keep your phone on, etc., etc. So this is something given to the student, whoever they are. How do I come out of this? Click panama. To every student, it's emailed before they start my posting. So we have already set the tone. I have given my rules for what I expect from them as a professional in my posting. Okay. How do I go next? So the other technique that you can use is orienting the learner to the patient. It's a technique called priming. So before the patient, so we have different styles, right? Sometimes the patient is sitting in the room and you go into the room. In some hospitals, you are sitting in your clinic room and the patient is ushered in. So I'm sitting in the room. So before the patient is ushered in, I tell the PG, look, I look at the patient electronic record, I say, okay, this is what the patient is, this is what we are going to be looking for. So for example, I say, look, this is a 7-year-old child with myopia. 3 months ago, I gave glasses. Parent says vision is still blurred or is still blurred again. What points will you focus on in history? And what will you examine during workup? So I want them to start thinking about family history of progressive myopia, history of prematurity, is there excessive near work going on because of which the myopia is progressing, etc. So I want this for them to start thinking and tell me a few answers. Also tell me when the patient is sitting in the slit lamp, what are you going to look for? I will rule out K corners, I will do a streak to see if there is scissoring. I want these answers even before the patient comes in. So this is called priming. Another technique that is used is called framing. So let me tell you upfront, I'm sure you are all doing all these techniques every day. I'm just giving all these fancy names. So next time somebody asks you, so what is your style of teaching? You say, I do priming and framing. So it just sounds a little cool. So the other thing you can tell them is, framing is what you should be doing and in what time. For example, I'll tell them, look, this is a 4-year-old child, very cooperative kid, history of photophobia and nystagmus. I want you to examine the anterior segment for possible causes. You can take 10 minutes. I'm going to run, get myself a cup of coffee. I'll be back. I want you to have examined anterior segment in 10 minutes. So you're also getting them ready for the exam, because exam is a very time-bound thing and very focused sort of examination. So this is called framing. Next is teaching with the patient in the room. Okay, so what are the other things you can do? So we are going to look at this under the title called the 1-minute preceptor. The 1-minute preceptor is a technique in which you get a commitment, probe for underlying reasoning, reinforce what was done well, teach a general rule, correct errors. And we look at these. So it only takes a minute to do all this. That's why it's called the 1-minute preceptor. So get a commitment. For example, here's in front of you, the PG is examining. He says, what? So you say, hey, what is different about that optic nerve in the right eye? You may need to ask 1 or 2 questions for clarification. You say, are you sure what you are seeing is a large cup? Or could it be a differential diagnosis for something else that appears like a large cup? Common pitfalls as a teacher you do is you jump in with the answer. What? Yeah, I showed you the coloboma last week. No, it means over. You already told the answer. So don't do that. Don't jump in with the answer. Sometimes you take over the case with asking too many questions, and then they get confused. So, okay, start telling me all the anomalies of the disc that can be that can present, congenital anomalies, and then they get lost. So what they were examining is gotten sidetracked. Next, probe for underlying reasoning. What led you to think that it is a large disc? What else did you consider? So then you know what are the gaps in the knowledge. If you do not mention coloboma of the disc as a differential diagnosis, then you know this person has never really focused on anomalies of the disc. Okay? Reinforce what was done well, give positive feedback. You say, excellent, I like the way your technique was, you kept the light less, you kept the patient comfortable, the slit lamp was adjusted well, I really liked your technique. Teach a general rule. For example, you say, when you see a patient, a small child, with poor vision and the ocular exam looks normal and you've concluded it's a normal disc, vision is still poor, think of CVI, ask for history of neonatal problems. So you teach a general rule. Correct errors. Self-assessment in more senior students, you ask them, what do you think you did wrong? What was wrong with your technique? Provide constructive feedback with recommendation for improvement. Couple of more slides. Teaching in the room, direct observation. You can observe a portion of learner's interaction with patient and skills not commonly observed. For example, you can stand quietly and look at how they interview the patient. How are the physical examination skills? You see, how is he doing a cover test? How is he doing ocular motility? Is his pupil re-examination technique correct? Just you can quietly stand in a corner and watch. Rather than they only telling you the finding, the exact technique you can watch. And you can say, now, okay, I want you to break the news to this patient. I want you to counsel him about his cataract. And then you stand and watch how he does his communication skills. So it reinforces trainee's role and opportunities for meaningful feedback is there. So direct observation caveats. Learner and patient need to be oriented to the exercise. For example, applanation, you say these points in your applanation technique I'm going to watch. And then you have to make sure to take the patient consent, especially if it's going to be a gonio or something that they're going to touch the eye, and the patient obviously knows this is a learner. You need to get the patient's consent. And observe without interrupting, give feedback after the patient visit. Presenting in the room increases the face time with the patient, reinforces the trainee's role. You can go directly to the examination of the patient. Patients actually in a study found that they liked students presenting their history in front of them. It was nice. The patients felt good about it actually. So what we are doing is, I guess, right. Few other thing about presenting in the room caveats are, for example, I'll tell you an example of coloboma. See, take care of what is said and how it is said. Patient might be uncomfortable with certain discussions. Pick appropriate cases. If incorrect advice is given, be gentle and give alternative suggestion. If partially correct, then affirm what the trainee said and add detail. Discuss with trainee privately. I'll give you a quick example. So I had a patient with coloboma who had an RD in one eye, and the other eye I'd asked the student to examine. And he blurts out saying, "Madam, I think I see an ICM detachment. That means this patient is going to get an RD in this eye also, no?" So that is not something that you want the, it is true, but you do not want the patient to be hearing this in that way. So in such situations, you gently come and say, intervene and say, theoretically it is true, but it is not automatic that if you have ICM detachment, you need to have a retinal detachment. So you can slowly turn away. We are going to involve a retina colleague's opinion also, and let's see. I don't think it is necessary that it's an automatic complication, or some way in which you steer away from what the trainee has uttered. So this is a risk of having the trainee say too much in front of the patient also. Modeling. Clinical teachers are powerful role models. The level of enthusiasm for teaching, display of compassion for patients, how you handle difficult patient encounters, how you provide informed consent, all this can be learned by just the student standing quietly in a corner and watching you. So you're a model. So this technique of teaching is called modeling. And at the end of the presentation or the end of the day, encourage the PG or resident to reflect on the patient cases, consider areas that he/she may need additional improvement. Ask the learner to research answer for a certain question and come back and tell you the answer. Let me just go back one second. So ask them questions like, do you have any questions based on the patients you saw today? What was the most important thing that happened today? What is the one thing that you would like to learn more about from what the patients you saw today? So in conclusion, the 1-minute preceptor, modeling, direct presentation in the room, and initiating self-directed learning are the many techniques that can be used for teaching in a busy clinic.